Thank you for asking me to participate and for putting this on. I can't imagine that this was a small endeavor in any way, shape, or form. And thanks to our listeners for this test run that we are going to do today. In knowing that this is going to be the first in a series of many webinars that Solving Cancer is going to put on, while we will definitely talk about our T-cell work here, I thought it'd probably be a good introduction to kind of go over immunotherapy and the three types of immunotherapy used in neuroblastoma treatment in general. Kind of the large focus of the talk really will be on our T-cell work, but we'll talk about monoclonal antibodies as well as vaccine-based therapies. For all of you guys, you're really aware of this data, and you probably know it better than a lot of physicians do. But the neuroblastoma essentially accounts for 8 to 10 of all pediatric cancers, but unfortunately leads to about 15% of all pediatric cancer deaths. And while survival is really good for those patients with low and intermediate risk disease, upwards of 85 to 90%, what we know is for those patients with high-risk disease, and although this data is relatively old for the research setting, we've still got room to improve with published survival rates through COG prior to the antibody study of 30 to 40%. And as you guys are aware, treatment involves surgery, radiation, chemotherapy, biologics with synthetic retinoids like Accutane, as well as monoclonal antibodies that we're using in the upfront setting. But we're really going to discuss today some immunotherapy and immunotherapeutic options for our patients with neuroblastoma. So to start from the beginning, as what is immunotherapy? It's really using the immune system to help the body eliminate cancer and disease. It was first discussed in the late 1800s when Dr. Coley had a patient who had metastatic sarcoma, and this particular patient developed a bacterial wound infection, and all of a sudden, a few of her metastatic sarcoma sites got better. And so there being a link between the immune system and improvement in disease was first really noted at that point. We're using immunotherapy right now because it really allows us to be able to target tumor antigens or pieces of the tumor cell that are hopefully seen more commonly in tumors and not really on normal cells, with the overall goal that if we're able to target specifically more tumor cells instead of normal cells, that treatment should be associated with less side effects than standard chemotherapy. But neuroblastoma, as you guys can imagine, like many other solid tumors, is a pretty savvy tumor. Its expression of tumor-associated antigens really varies. So even in our patients that have high-risk disease, even in our patients that have MYC and amplified disease, even in our patients that have ALK mutations, we still know that you can get different tumor-associated antigens within that smaller subset. So trying to find the appropriate one does become slightly difficult. We also know that neuroblastoma, like many other solid tumors, has become increasingly more savvy by being able to decrease the expression of things like MHC class 1 and class 2, which are essentially molecules that are used by T cells in order to recognize the fact that these are tumor cells, that these are foreign, and they need to be killed. And tumor cells are able to secrete inhibitory cytokines and proteins into its microenvironment, or basically the area where it's located, such that it can convince the immune system that it's normal and that it should be left alone. For people who are more visual learners, I really like this slide a lot because it goes through all of those things. Essentially, tumor cells, solid tumor cells, were what this particular article was about, but really for neuroblastoma, it's able to downregulate those MHC class 1 and class 2 molecules so you don't get recognition by tumor-specific T cells. It can secrete things into its environment that essentially cause the immune system to not be able to work. And it can upregulate things like T regulatory cells, which are normally used by the body such that the immune system knows that this is normal and it shouldn't be attacked and recognized. And it can kind of take those tumor cells and those T regulatory cells and, again, convince the body that the tumor cells are normal and that the immune system shouldn't attack it. And so we and other groups across the country are looking at forms of cancer immunotherapy that can really attack those different aspects of how neuroblastoma has been able to fool the body into being able to consider itself as being normal. There are three main types of cancer immunotherapy: monoclonal antibodies, vaccine-based therapies, and cellular therapies, and we'll briefly talk about all three in the next few minutes. So monoclonal antibodies, I'm sure the majority of you guys are familiar with, and essentially what they're able to do is take a very specific antigen or tumor-associated protein, and they're able to bind to it. Once they're able to bind to it, they can cause tumor death in one of three different ways, and I'm going to be relatively brief in this aspect. But essentially, you can have macrophages and natural killer cells or members of the immune system be able to bind to the Fc portion of the antibody and then be able to kill the tumor cells directly, and that's called antibody-dependent cellular toxicity. You can have the ability of complement or part of the immune system cascade be able to bind to the antibodies and then start a proteolytic cascade, or basically a set of enzymes that allow the cells to be degraded and then to die, and that's more of your complement-dependent cytotoxicity. And then an off product of that is the C3b, and this C3b molecule here, when it's on tumor cells, can then bind to natural killer cells and macrophages, our friends from down here, and then again allow for killing of the cells in that direction, and that's more of a complement-dependent cell-mediated toxicity. So monoclonal antibodies are great, but they have issues, as many of you guys are aware. The mouse form of the monoclonal antibody, most of you guys will recognize that as 3F8, is great in that you are able to have very good specificity for whatever that particular antigen or piece of the tumor is that you're looking for, because you're basically able to construct it in the lab. But the body eventually recognizes the fact that mouse isn't human and that mouse is foreign, and it forms a HAMA, or a human anti-mouse antibody response, to try to get rid of and to destroy the fact that there are mouse pieces running around in the body. Patients can have full-fledged allergic reactions, they can get swelling, they can have blood pressure elevations and decreases, and so really over time we realized that in order for immunotherapy to be more efficient, we really need to decrease its immunogenicity, or essentially the response that the immune system has to antibodies. So what we wanted to do is to take mouse antibodies and really make them more human, such that the body won't try to reject them. You do that in a couple of staged ways. First would be making it more chimeric, such that you have more of a human structure and less of a mouse structure. That, in relative to neuroblastoma terms, would be like CH14.18. And then you can actually make it more humanized, such that about 90% of it is human structure. For people who are aware, there's a humanized form of 3F8 that Memorial is now doing testing on. And eventually you want to get to really a more human structure altogether, such that you don't have the potential for responses. The concern is always, though, that the more humanized you get, while you decrease that immunogenicity, you have the potential to decrease the specificity. And so really it becomes a balancing game of how far you want to go with not having the immune side effects, but being able to actually bind to and then kill your targets. So like we discussed, 3F8 was really the first monoclonal antibody used in clinical trials for patients with neuroblastoma. It targets GD2. The fancy name for that is a diethyalloganglioside that's seen on almost all neuroblastoma cells. And 3F8, as many of you guys are aware of, does have some pretty significant side effects with pain, fever, blood pressure abnormalities to full-fledged allergic reactions. 3F8 has been exceedingly helpful in combination with GM-CSF. For those patients with a low burden of disease, so isolated bone, bone marrow, or really, really small solid tumor lesions. And it's been used at Memorial in combination with GM-CSF as their consolidation instead of high-dose chemotherapy with stem cell rescue like is done at many other institutions, because in their hands there wasn't a difference in the outcome. When talking about a more chimeric form of the antibody that's, again, targeting GD2, that would be CH14.18. The Children's Oncology Group has recently published their initial phase 3 study results, where they looked at patients who were at least under 31 at the time of diagnosis, had had at least a partial response after induction, and then completed high-dose chemotherapy, stem cell rescue, or autologous transplant and radiation. And they randomized those patients, so half of them got Accutane, or cisretinoic acid, and the other half got cisretinoic acid plus the chimeric antibody plus GM-CSF as well as IL-2. And when they found, when they were doing an interim analysis, is that the 2-year event-free survival, there was a 20-point difference in that people who were on this combination with a chimeric antibody, GM-CSF, and IL-2 were having a decreased chance of relapse, so 66% versus 46%, and that the overall survival at 2 years was again improved by about 10%. The FDA required COG to do an additional safety study that recently closed to complete its licensing. It has been sold to United Therapeutics, and the conversion over to the United Therapeutics agent should be taking place within the next 3 to 4 months. When thinking about, again, being able to make things more humanized and potentially decrease the toxicity that you're seeing, there's a study that's being conducted at St. Jude where they've got an identical variable region, CH14.18, and I apologize for that. And I'm not really sure how to make it happen without hanging up on him. So, in this particular case, the variable region here still does bind to GD2. It is humanized, so in theory it'll be less immunogenic. But it has this modified FC portion, and again, the FC portion was the portion that was used to bind complement, and it's really thought that a lot of the issues with pain, neurotoxicity, blood pressure changes is really due to this complement activation, and so they're evaluating in this particular study whether modifications in this region are going to help in that area. But in general, there are lots of other things that you can do to monoclonal antibodies in order to be able to improve their function, one of which is being able to tie them to radioactive particles, again, to make them more specific. We've talked about being able to mutate them. Dr. Sundel's group, also in conjunction with the Children's Oncology Group, has studied a CH14 immunocytokine. And what that does is instead of taking IL-2 and having to do the long IL-2 infusions, it links the IL-2 cytokine to the monoclonal antibody, and you administer it that way with hopefully being able to decrease the toxicity you see from giving IL-2 through the IV and being able to utilize the positive effects of IL-2 directly in the area where the monoclonal antibody is. So when talking about cellular therapies, where we'll spend the majority of this talk, there's lots of work that's being done from an NK perspective and a T-cell perspective. There are groups like the group at Memorial, the group at MD Anderson, and some of the groups up north that have really worked with T-cells, with NK cells. But our group has done quite a bit of work with T-cell-based therapy. And that's really because we are piggybacking on what T-cells normally do. So T-cells are part of the immune system that would normally help to fight infection. So it's their job to be able to traffic through multiple tissue lanes to get to those sites of infection to be able to clear disease. We know that T-cells in general have efficacy against solid tumors. Again, like with nasopharyngeal carcinoma in the adult setting, a lot of this work was done in melanoma out of the NCI. And we know that it can be efficacious in patients with solid tumors that have bulky disease as well. And through some initial work that was done by our group when they initially were at St. Jude before they moved to this institution, we know that when we gene-marked T-cells and then gave them back to patients, we've been able to identify those gene-marked T-cells in the body for upwards of 10 years after that initial infusion. So once they're given, they're able to use the body's own proteins and cytokines to be able to amplify and continuously live within the body. But instead of using just T-cells in general, we really wanted to make them more specific for neuroblastoma. And in order to do that, knowing all of the things that neuroblastoma is able to do to kind of make itself invisible to the immune system, we added what's called a chimeric antigen receptor to neuroblastoma cells. And these chimeric antigen receptors targeted GD2, again, because we know that GD2 is on almost all neuroblastoma cells, and you typically do not see downregulation of GD2 if that's your target in tumor cells. In order to create chimeric antigen receptors, what we do is we start by taking that variable fragment of the monoclonal antibody, or the part that recognizes the antigen and allows it to bind. We link it with the signaling portion of the T-cell receptor complex, such that you get the specificity of the antibody, but the activation of the T-cell to then allow the T-cell to help kill tumor cells. When we initially did this study that many of you guys may recognize is our study that we called Nestle's. We have a little bit of a food obsession here in Houston. The primary objective of this study was to look at the safety of these GD2 chimeric antigen receptor T cells when given to patients with high-risk neuroblastoma. And secondarily, we wanted to see if we could really look at how long these cells were lasting within the body and how efficacious they were being as far as having tumor responses. And a lot of this was because the initial work done, again, with other solid tumors like melanoma on the East Coast, they were finding that these cells weren't lasting for a long period of time. And so we were hopeful that by a combination of different things that we'd be able to see some persistence as well as anti-tumor effects with using targeted CAR therapy. So we treated 19 patients on that initial study on 3 different dose levels. The median age was about 7 years at the time of their infusion and ranged anywhere from 2 to 20 years of age. There were 22 infusions of 44 different products, and that was because 3 patients had multiple infusions. And what we noted were there were no dose-limiting toxicities. At the time of their infusion, we had 8 patients who had no evidence of disease, 3 immediately after high-risk therapy, 5 with a history of relapse but NED at the time of their infusion, 4 that had relapse active with very limited disease, 3 with solitary bone lesions and 1 with bone marrow disease, and then 7 patients that had relapsed bulky disease. What we found after infusion is of our 8 patients with no evidence of disease, the median time to relapse was approximately 411 days, and of our patients that had no evidence of disease immediately after high-risk therapy, we've had no recurrences thus far. Of our 4 patients with relapsed active but limited disease, we had 3 complete responses, 2 with solitary bone lesions, now 5 and 7 years out respectively, and 1 patient with bone marrow disease who did subsequently have a systemic relapse and has died from her disease. And then of our 7 patients with bulky disease, we had 1 who is currently alive with disease. But from a response standpoint, what we saw for those patients that had active disease at the time of their infusion was about a third had a complete response. We had 1 patient with a partial response, 1 patient with stable disease, and 2 patients who had evidence of tumor necrosis, or basically tumor death, in areas where we knew that they had active disease, and we did biopsy prove these 2 particular cases. Many of you guys have seen this image before, and this is our patient who is now 7 years out. She had evidence of a dural lesion that responded within 4 months. It became MIBG non-avid, and again is now 7 years out with no evidence of active neuroblastoma. One of the things that was interesting about this study that was a little bit unexpected, and again, that's kind of based on some of the data that we had seen from the adults, was that we were able to detect these cells out for much longer than was seen in the adult population, upwards of 4 years in our patient who is now 7 years out. And when we tried to go back to figure out what was different about this particular product as compared to what had been historically used, it was that we found that the higher your T helper cell or your CD4 cell percentage within the product that we gave you, the more likely we are to see the cells last for a longer period of time. Why does this become important in general? And that's because a lot of people who are looking at T-cell-based therapy, in addition to our pediatric and adult colleagues, some of them were doing just a component of T cells or the CD8 component. The CD8 component is more your effector, the cells that actually go through and do the killing, and your CD4 cells, while they can do the killing too, are really supportive. And so a lot of people had chosen to just give that CD8 population to patients, and that may be why they weren't seeing them in the body, in the peripheral blood as long. But in our particular case, we noted that having those CD4 cells actually caused us to be able to detect the T cells we administered for longer. Was detection for a longer period of time important? And in our hands it was. For those patients, again, with active disease, if we were able to detect your cells for 6 weeks or less, your time to relapse was relatively quick, versus those patients in whom we could detect cells out for 6 weeks or greater. Again, some of those patients we now have as long-term responders. And so what we learned from this particular study was there were no severe dose-limiting toxicities. first-generation cells could be detected at low levels for an extended period of time, which was, again, different than what we had seen before and what had previously been reported, but that having CD4 cells within that product was important, and that we were seeing clinical responses, including complete responses after infusion, with about a 45% response rate when we looked at complete, partial, and stable disease, and that there was a longer time to progression if we could detect the T cells that we administered in the body for more than 6 weeks. But we knew that there were ways to improve upon the data that we were actually seeing, hence the slight delay between that particular study and the study that's actually just gone active as of today. And that was because there had to be ways to improve the proliferation and had to be ways to improve the amount of time that the cells were surviving in the body after infusion. What we knew with these first-generation cells is while they were able to kill, they were really getting incomplete activation because they weren't getting additional co-stimulation, because we, again, know that neuroblastoma is smart and it really gets rid of those markers. And so instead of relying upon the neuroblastoma to do it itself, we and other people who are looking at CAR-based therapies for solid tumors recognized that a more efficient way to do it would be to put the actual co-stimulation molecule within the receptor itself. So in addition to just doing one portion, we then added the co-stimulation portion to give us a second-generation CAR, and we've now moved into the world of third-generation CARs where there is an additional component that allows for improved survival. So with our first generation, that CD3 component, you were really looking at cytotoxicity, so being able to kill the cells. The second generation, you were able to add on that CD28 co-stimulation component, and so you were getting increased proliferation and cytokine production. There are a couple of studies that are up and running using second generation chimeric antigen receptors. That's really more so in some of the brain tumors and some of the leukemia studies. And then from a third-generation perspective, that also improves your survival, and that uses a combination of additional co-stimulation molecules. And so with those third generations, there is using OX40 as a co-stimulator, and there's using 4-1BB as a co-stimulator. They both belong to the same stimulation or tumor necrosis factor receptor superfamily, and you need either one of them to become a third-generation chimeric antigen receptor. All of the other studies that are using third-generation CARs right now use 4-1BB. We're going to be the only ones thus far that are using OX40. And the reason we chose to use OX40, and so therefore to be a little bit different, is because we found that OX40 was really important in being able to activate the CD4 cells. Additionally, at the time that we were generating constructs with OX40 as well as some constructs with 4-1BB, there was a patient who died who had colon cancer and was being treated with a chimeric antigen receptor that was a third generation that had 4-1BB but was targeting HER2. And so that death was eventually thought to be linked to T-cell activation caused by a cytokine storm. So it essentially revved up the immune system so much, released all these cytokines that the patient died from that effect. And so because of all of those things, that was our reason for moving with the OX40 construct. For many of you that, again, may be familiar with chimeric antigen receptors in pediatrics, one of the more famous studies that's being done and is being publicized right now is being done at CHOP, where they're looking at third-generation chimeric antigen receptors for patients that have leukemia. They, too, have a 4-1BB component, and you may have heard about some of the cytokine storm issues, especially with that first patient who, in the end, has done so well, where they get super sick. And so it is a known side effect of that particular agent. In theory, it may be a known side effect of OX40. We're not sure yet. But because of that, we added an additional level of safety with adding a suicide gene component to this particular construct. It's called inducible caspase-9 or iCaspase-9, and essentially what it allows us to do is if we're seeing really significant side effects, we can do an IV infusion of what's called AP1903, or a small molecule that basically turns on the safety switch, and it causes rapid cell death of the particular chimeric antigen receptor cells. And so our study that is now active for patients with neuroblastoma looks at the infusion of these third-generation GD2 chimeric antigen receptor T cells that are modified with the safety switch in order to see if we can get sustained proliferation and persistence of these cells, with the thought being that, again, if we're able to see the cells last for a longer period of time and they're able to be more active, we're hopeful that they can have increased anti-tumor effects for our patients with disease. And so, in conclusion of this section, it's really these first-generation GD2 CAR T cells that we know have been safe. We've seen them at low levels for a long period of time, and they were having anti-tumor effects. And really what we've spent the last few years doing is not only looking at the work that other groups have done, but really being able to focus on improving proliferation and persistence by moving to a third-generation construct. But because of all of the safety concerns out there, we've incorporated a safety switch into this component, that iCAS-based9 system, with the hopes of being able to decrease any potential toxicity that might be related to the infusion of these cells. And so lastly, just a couple of slides about vaccine-based therapies. And what we know that, again, vaccine-based therapies are relatively new in the neuroblastoma immunotherapy armamentarium. They're a little bit more challenging as far as generating them, and that's just because, again, you have a large variety of tumor-associated antigens in neuroblastoma, and many vaccine-based therapies target a single antigen. So unless you're targeting something like a GD2, you sort of have to pick and choose what is going to be the most prominent thing to do. And unlike GD2, a lot of the other single antigens that might be targeted can downregulate themselves when they realize they're being targeted and lead to immune escape. So you can use things like tumor cells themselves for the vaccine product, with the thought that they should have a more relevant source of those tumor-associated antigens. And there are two different types of tumor cells that you can get. You can either get tumor cells from the patient, autologous tumor cells. They're more likely to contain all of the relevant antigens because they're the patient's own tumor, but it's difficult to obtain, and they're exceedingly expensive to grow and to maintain and infuse. And so a lot of us have been moving towards a more allogeneic or an off-the-shelf product because it's slightly simpler to make, it's easier to control, and it becomes transportable once we're able to prove that it's been effective. And so although I borrowed this slide from a different company, I really think it kind of very easily explains how these off-the-shelf products work, in that you initially start with cancer cells that are not recognized by the immune system. You can go ahead and give your tumor cell vaccine, and what that does is essentially causes inactive immune system cells to become activated. These activated immune cells, and again, I apologize for the phone call, these activated immune cells can then recognize and fight other cancer cells, then leading to death of those cancer cells from the patient. So in addition to doing it that way, there are some ways that you can genetically modify the tumor cells to increase the immune response even more. You can modify these tumor cells to have those MHC class 1 and class 2 molecules such that they can be recognized by the T cells that can then learn and process it and be able to identify pieces of tumor that are located in a different location. You can add those co-stimulatory molecules that will, again, make your T cells and your immune cells more active when they come in contact with the tumor. And you can have the tumor cells secrete cytokines that can recruit other members of the immune system to then be able to help fight and eliminate disease. And so in conclusion, immunotherapy, again, is utilizing what the body already has in its immune system to be able to help eliminate and fight cancer, and really doing that with targeting tumor antigens such that you can see them on tumor cells, not really on normal cells, hopefully, such that we can potentially decrease side effects and decrease long-term toxicities. What we have seen, what the group at Memorial has seen, what lots of other groups that have been doing immunotherapy have seen, is that the best clinical results thus far have been when those patients have had a limited amount of disease, again, either isolated bone, bone marrow, or small solid tumors. And so many of us are working from a clinical perspective with both antibody, cellular therapies, and vaccine-based therapies to really figure out ways to improve response, overall survival, not only in those patients with limited disease, in those patients with bulky disease, with the hopes that we can eventually move it to the upfront setting to potentially decrease the risk of relapse and having to go down this route altogether if possible. And so just really quickly, as you can imagine from a clinical study perspective, this takes a huge team of people. We have the people in our translational research lab, our clinical research team that helps us put together the protocols and get all the FDA, IND, regulatory stuff taken care of, and the people in the lab who actually grow our cells. The support we get from our cancer center is phenomenal, as well as the NCI and the NIH. But what I'd like to say is it also takes a huge amount of foundation support, and so groups like Solving Kids Cancer and Cure Kids Cancer Foundation and a lot of our other foundations have done incredible jobs being able to allow us to actually take things that we think are important and can potentially be useful from the bench into clinic, and a lot of what we do could not be done without you guys. And that's it. Thank you very much.
Thank you, Crystal. That was a fantastic presentation. You covered a lot of ground in 22 minutes, so I appreciate that. I wanted to remind people that we do have an archive of the webinar that will be available, and so we'll follow up via email and send you a link so that you can review some of these sections that you may want to see again. And also at the end, we'll give you a slide with Crystal's contact information, as well as our special webinar email. If you have follow-up questions that we don't get to cover today, we'll certainly answer them after the meeting, and it's very nice of you to provide your own email, Crystal, to follow up with people individually who may have very specific questions. I'm going to start with a couple of the questions that have been submitted, and just wanted to go back to one of the basic things about the T-cell, engineered T-cells as a therapy. The CAR seems to be an important part of the construct of T-cell therapy. So can you explain what the CAR is exactly and what's new about it compared to a child's own natural T-cell?
So let me skip backwards for a second. So one of the things that we know about the body and what it's able to do, back to this picture, is it's not able, because it can downregulate those MHC class 1 and class 2 molecules, that tumor-specific T cells need to be able to recognize the fact that it's tumor, to process it and destroy it. One of the nice things about chimeric antigen receptors is that since it's able to bind through this variable portion and activate, it essentially doesn't need MHC class 1 and class 2. So it kind of usurps what the tumor cell has been able to downregulate, such that the T cells aren't able to recognize it. So under normal circumstances, your T cell, my T cell, or anybody who has cancer, their T cell wouldn't be able to identify this is foreign, it needs to be destroyed, because those molecules are downregulated. The CAR essentially allows us to bypass that altogether. It doesn't need MHC class 1 and class 2. It can activate and destroy without that.
Okay. And then we have a question about bulky disease, which is a difficult disease type to have, as we all know. And in fighting bulky disease, often lots of other side effects occur because of high-dose chemotherapy, such as low platelet count, which can cascade into not having surgery or not having future treatment. So the question is about balancing the risk of continuing with immunotherapy before surgery rather than waiting until the counts recover and then doing immunotherapy. How would you sort of balance that or consider that issue?
So it's speaking just from a surgical perspective alone. I think from a surgical perspective, you can potentially transfuse platelets and transfuse blood and transfuse FFP and all those other factors that help to control bleeding. But because almost all of the data that's out there shows that immunotherapy is most effective in those situations, if surgery is feasible, I think it should be the next first step to be able to decrease your tumor burden. We have had some situations, like in the other tumor that I do a lot of work in, where surgery is just not an option, just because of the actual location of where the tumor is, kind of in that nasopharynx area behind the nose but in front of the skull. You just can't surgically get to it. And so from that perspective, we've been able to see that T cells can be effective and can work. It's a slightly different mechanism, but we know that it's possible. So right now what we're trying to do is fine-tune the changes that we're making in our T cells to be able to make those patients with bulky disease be able to respond as well, potentially if not better, as those patients who have a lower burden of disease. But right now, just with the mechanics of how things are working in the neuroblastoma realm, it's just been seen that patients from an immunotherapy standpoint do better if there's less disease. So if there's a way to do that surgically safely, I think that would be a good next step. If there's no way to do it safely, then you have the potential of going the other route, which is providing an immunotherapeutic to see if you can shrink as much as you can or debulk as much as you can from that perspective, potentially allow you to have more time for bone marrow recovery, and then move on to a surgical resection at that point.
So because T-cell therapy is so different than traditional drug or chemotherapy administration, parents may see that the response rate is different or lack of response, but typically a response, if there is one, would be different than what it would be in a drug therapeutic. So I just wondered if you could sort of cover what the potential difference is in this than what you'd normally see in a response from a tumor using a drug treatment.
So I don't know that I would necessarily classify them as different, because I think the general classification scheme of complete response, partial response, things of that nature are the same. Where stuff gets a little bit complicated, and this I think maybe it's probably how I'm interpreting your question, so you can ask it again if I'm not answering it the right way. Where things potentially get a little bit different is when you are talking about using immunotherapeutics in the setting of a small amount to minimal residual disease, in that either patients, for example, the vaccine trial that's being done by Dr. Krishner at Memorial, for those patients who had either very little disease or no disease after their first recurrence or subsequent recurrence. And so then it becomes harder to report that data, because what you're looking for at that point isn't necessarily response in the standard way that we look at complete response, partial response, because you're talking about patients who don't really have measurable disease, versus being able to, one, look at the amount of time it takes to potentially disease comes back. And so because you're looking at the amount of time, these studies tend to last a lot longer and potentially need lots more patients to participate on them. Or you're having to look for other measures of some form of success. So if you have a immunotherapeutic that modifies something very specific, is it a downstream effect that you can potentially look at that will allow you to know that things are working or not working? If it's something that this was a patient who had a minimal amount of bone marrow disease, and so you look in the marrow again and you're not seeing anything, there are some groups across the country right now that are looking at other PCR markers within the bone marrow to be able to detect really, really small amounts of disease, and or if they are increasing your risk of relapse. So you end up having to look for the effects in a secondary area and or looking for the amount of time it takes until disease comes back. And because of that, how you structure the studies, how long the studies last, and how many patients are involved in the studies becomes a little bit different than when you're talking about standard chemotherapeutic agents in patients that have lots of disease that you can do that regular MRI, MIBG, CT scan to be able to assess response.
Hi. I just had another question related to something we didn't talk about but may be considered immunotherapy, and that's bone marrow transplant.
Mm-hmm.
From the researchers that we've spoken to, they seem to agree that we've taken bone marrow transplant as far as we can with kids with neuroblastoma. So the question is, do you see this type of treatment, adaptive cell therapy, as potentially being the replacement for bone marrow transplant in the future?
I think it will do one of two things. I think bone marrow transplant And we do have some investigators in the U.S. as well as some investigators in Europe that are doing it now, where transplant isn't really the high-dose chemotherapy stem cell rescue and that's it, but thinking more of transplant as the lymphodepleter or the preparative regimen before your immunotherapeutic. So one of the things that we know about what the guys at the NCI do for adults is they give some pretty heavy-duty chemotherapy before they give their cellular products, with the thought being that if you can essentially get rid of the patient's immune system for a short period of time, the body will do what it normally does, which is rev up its own what we call kind of homeostatic cytokines, or basically its own GCSF and everything else to say, hey, your immune system's not working, we need you to kick in and to grow new cells and proliferate and to make sure that we're okay. And then essentially, you're able to give your immunotherapeutic product in that setting where the patient is lymphodepleted, such that your T cells, your NK cells, your whatever, are able to use all of your body's own normal response to then be able to grow and to expand and to proliferate. And so using transplant not from the setting of transplant, but using transplant really as more as a preparative regimen for immune-based therapies, I definitely see in the imminent future that happening. It's definitely happening in a couple places here now and then a couple places in Europe, but really using it more widespread. It's potentially even in a ultra-high-risk population. I can definitely see that in the imminent future. There have been a lot of discussions as to whether or not transplant in and of itself will go away, and I think if you're going to put me to task on this one, I think it probably will. But I think there's going to have to be a combination of things that replace it that are far more specific. Right now, transplant really is the old-fashioned, we're giving you a whole bunch of stuff to try to get rid of all of those cells that we know are there and that we can't see. And then we're essentially rescuing you with your own stem cells such that you don't die of infection or bleeding before your body is able to recover on its own. And so once we get to a point where we really have other agents that are very specific for those cells that we know that are remaining that we can't see, I think transplant, as simply transplant, will go away.
Got time for just a couple more questions. Here's a real specific one. Related to the graphic you shown, there was a nice diagram of the tumor cell in relation to the monoclonal antibody activity. You showed that there's many methods of killing, including dendritic cells, the complement components. The question is there a risk that cytokines can downregulate the method of killing that is actually relevant to the specific tumor? So since each child's tumor is different, and then is there something going on to potentially determine which mechanism is the relevant one for a particular child's tumor so that it can be more personalized with the use of cytokines?
Yes, there is the potential that you can have cytokine activation that can lead to an immune system or a T cell energy. Or basically, you exhaust the cell's ability to function and to kill. That has been shown definitely in mouse models, and it's likely happening in humans, although it hasn't been definitively proven in a pediatric tumor subset, because I think it would just logistically be a little bit hard to do in an actual person right now. And so are we modifying the way in which we're given cytokines or the way in which we are looking at it? Yes, more so right now in Petri dishes and in mice in general. Are we at the level where you'd be able to individually take somebody's tumor and their T cells, NK cells, and monocytes, macrophages, and be able to look? We're not quite there yet. I think what will happen is we'll have to prove it on a larger mechanistic standpoint, and then once we're able to prove that we can accurately reproduce the data from that standpoint, then you can one day talk about moving into individual people. But yes to the fact that there are some cytokines that can do it, and yes to the fact that we are looking at ways to either modify the cytokines, adjust the doses that are being given, give different cytokines completely and altogether, such that we can get to a point where one day we can be more individualized.
Okay, great. for the last question, I'm going to combine two into one sort of big question, I guess. The question is about T-cell therapy potentially being a standalone or monotherapy that's highly effective, but more than likely it's going to be used in combination with other modalities. And then, so the comment is about what you think that would look like potentially, and then just a general statement about the future and what you see for immunotherapy or T-cell therapy, you know, in 2 to 3 years from now.
So the short question is, we would all love to get to a point where T-cell-based therapy could do it alone, but the honest answer is that, like many other agents, you will probably need to do them in conjunction with something until we are able to scientifically construct the T-cells and their recognition and killing components to a point where we don't need to do that. So people are definitely working in that direction. It's going to take a bit of time. In knowing that it's going to take a bit of time, I think it's going to be the combination of agents that are likely going to be the things that we see within the next few years. And there are a couple of things that even we are looking at as far as being able to piggyback on other different types of agents that are currently being used in a neuroblastoma setting from a relapse refractory standpoint, not just from a chemotherapy standpoint, because there are pluses and minuses to using straight chemotherapy, because you also have to worry about potentially killing off of the cells depending upon the dose that you're doing it in. But whether or not we can use other agents that we use in neuroblastoma treatment right now as the sort of lymphodepleter prior to being able to give T-cells. There are also some really, really interesting immunotherapeutics from a monoclonal antibody standpoint that have come out within the last few years that, again, we're seeing more so used in the adults, the PD-1 inhibitors and things of that nature that are really specific checkpoint inhibitors as far as T-cell activation and downregulation of some other agents that I think would be really attractive in combination with cellular-based therapies. And so from a stepwise fashion, what we need to do is prove that what we're doing right now is significantly toxic, does have some increased issues with proliferation and the cells being able to last for a longer period of time, hopefully also having huge amounts of anti-tumor effects, and then being able to use this in combination with other modalities that are currently already out there that aren't going to be, well, we have to wait for this drug company to do this and we have to wait for this to do this. Things are already in the clinic right now to piggyback on those agents, and that's actually where I see us in the next couple of years, piggybacking on kind of one of two directions with our T-cell-based therapy to really make it more potentially beneficial for all patients.
Great. Well, I want to thank everyone for attending. This is our first webinar in a series, as I mentioned, so we appreciate your patience and sticking with some of the technical difficulties that we may have had at the beginning. We're going to have that ironed out for the next time. We're going to send you emails that would include, as I mentioned, the link to the archive of this webinar, and we'll also follow up with you with our next webinar and the date and the time for what that is. And I wanted to also provide you with a couple contact emails. I think, Crystal, it's at the very end of the deck.
Yes.
So you're kind enough to provide your email for follow-up questions specific to some of the areas that you discussed. So we appreciate everybody submitting questions. If you do have follow-up questions specifically for Dr. Lewis, her email is at the bottom of the page. If you have any questions for us and want to follow up about the webinars we conduct, our email is webinars@solvingkidscancer.org. I really want to thank you, Dr. Lewis, for taking time out of your busy day to do this. You really helped us by being informative and being patient in describing this to a group of us who need it to be described in a very, layperson-friendly way. So that was fantastic, and thank you for the research work that you do specifically, because you're really pushing the frontiers of what we hope are the curative areas of clinical research for the future. So we hope you have tremendous success, and we want to thank you for all that you do for children and families.
Well, thank you very much again for having me and for all of the work that you guys do. I mean, again, a lot of what we do couldn't be done without all of the advocacy work of all of our families. And while a lot of my families here will say, my standard line is nobody ever wants to become a member of our family, but once you do, all the things that you guys really have stepped up to the plate to be able to do to make things better for the children that come after our current patients is absolutely phenomenal. So thank you.
Thank you for the kind words, and thank you all again, everybody, and we look forward to having you participate in the next one, which should be within the next 6 weeks, and we'll send you emails to alert you to when that is. Thank you again, everybody.